Hi, you guys. My name's Mary Claire. I'm one of the nurses here at Stanford Children's in the allergy department, and I just want to welcome you guys and thank you so much for coming. We just wanted to host this event to empower you guys with knowledge. Whether you have a food allergy or someone you love has a food allergy, we know it can be really scary, and so we kind of want to go through some topics that are common topics that we think will help you. So we'll go through 3 different lectures, and then we'll take a 10-minute break. If you have questions, please write them down, and we'll do them at the end in kind of a panel style. And then we'll do the last 3, and then we'll do the questions. So I want to welcome up Dr. McGee. He's going to talk about Food Allergy 101.
All right. Thank you for coming. So the fact that you are here tonight means that probably at some point in your past, you have been, say, feeding your child, and you looked down and you looked at your child and you thought, whoa, what is that? There's some kind of rash. Something was going on. You were worried about that. And the point of this boot camp here tonight is to give you the knowledge and the tools that you need to be able to look at reactions like that, get a sense of how significant they might be, get a sense of what is possible and what is not possible in food allergy, what does happen and what doesn't happen, what can happen and what can't. We want to also, if you do have a food allergy, be able to know what to do when you do confront reactions, and to know what kinds of things are appropriate to ask for, and what kinds of things may not be so helpful. So I'm going to start out by looking at the different types of reactions that we can have to foods. Now, if you come into the clinic and you start telling me your story, the first thing that I'm going to be trying to figure out is whether we're talking about a specific food reaction or a general food reaction. So specific food reactions happen in response to eating a particular food, and they'll be very closely linked to a particular species of plant or animal, or a specific type of protein. And also very important in a way that helps us kind of determine whether an allergy exists or not, is looking at how consistent and how reliable that reaction is. Specific food reactions, especially those due to allergy, are driven by the immune system, and the immune system is very particular about the things that it recognizes. And so when you have a specific food reaction, you will react to that food every time you see that food, and you will never react when you don't have it. So that helps us, through the history, get some sense of what the meaning of a food reaction is. Now, general food reactions are a little bit different, and they have very different mechanisms that underlie them. So a general food reaction can occur sometimes with any food eaten. So somebody comes in and says, whenever I eat, this happens. Or it may occur with broad classes of food, like, say, fatty foods or spicy foods. If every time I eat fatty foods, I get abdominal pain or something like that. They may be less reliable than specific food reactions, and in general, those kind of reactions are not going to be driven by the immune system, which again is very particular about the kinds of things that it recognizes. So I'm not going to talk a lot more about kind of general food reactions, because those things really belong to the gastroenterologist, and that's where we would send you for those kinds of problems if we determined that that's what you had. But we are going to talk more about specific food reactions. And this is up here to break that category of specific food reactions into another couple different classes. And because now we have to decide, well, you are having a reaction to a specific food, but is that food reaction driven by your immune system reacting against a particular substance, or is it not driven by the immune system and has some other mechanism that underlies it? And if it is driven by the immune system, well, then is it actually driven by IgE, which is that allergic antibody that we make in response that causes allergy, or is it by, again, some other mechanism that might still be immune-based? So I'm going to go through a few examples. There's a whole list here of different kinds of reactions, and these are all the kinds of things that we're considering when we do see people in the clinic. But I'm going to talk about a few specific food reactions to give you some kinds of idea with regards to this. So here, the first example here is lactose intolerance. Now, lactose intolerance is a specific food reaction. It occurs when you eat milk. It doesn't occur when you don't eat milk. And it is what is going on when you have lactose intolerance is that when you take milk, you are so when babies are first born, they have to, of course, drink milk to survive. Mammalian babies, human babies, and other mammals. But once they are weaned, most mammalian animals never need to drink milk again in their entire lives. So they lose that ability to digest the lactose sugar. Once you've weaned, that lactase goes away. You no longer can drink milk. And there are a great many places in the world where lactose intolerance is extremely common. And in fact, in the northern part of Europe, some parts of Africa, the Middle East, those are the only places in the globe, really, that the ability to digest lactose actually emerged over evolutionary time. So this is an example of a food reaction. It is a food reaction, but it's not driven by the immune system. The immune system has nothing to do with it. So, of course, you're not going to have anaphylaxis. You're not going to have inflammation from it. But you will feel sick when you eat milk. So we can move on to another type of food reaction. So this one, a little bit different, is an immunologic reaction. It's driven by the immune system. It's causing inflammation, and it's in response to a specific food. But it's not an allergy in the sense that it doesn't have anything to do with IgE, the allergic antibody that is responsible for anaphylaxis, hives, swelling, those kinds of things. So people who have celiac disease will have reactions to wheat and to other grains because of the glutens that are contained in the wheat. But IgE is not involved in this at all, and so there's no risk of anaphylaxis. So again, this is an example of a food reaction, but it is not, specifically speaking, an allergy and not driven by IgE. So what is caused by IgE? Well, the one that we're most concerned about here, which is anaphylaxis. Anaphylaxis, you're probably all relatively aware of what that looks like. People will have hives. They'll have swelling. They can have trouble breathing. They can wheeze. They can have their throat feel tight because of swelling in the larynx. And they can vomit. They can have, and most importantly for anaphylaxis, they have a bunch of these different symptoms all at once. And of course, they can have low blood pressure, and that, which is one of the most dangerous parts of it. So anaphylaxis results because you're making this IgE antibody, which is a protein that specifically recognizes proteins in particular foods. This has a very, these kind of reactions will have a very rapid onset. We call it immediate type hypersensitivity, and it's called immediate type hypersensitivity because it happens very quickly. Generally often within 15 minutes of eating a food, if not less, and certainly within 2 hours of eating the food. So when you wake up 6 hours later with symptoms, they're probably not due to an IgE process. Also, with anaphylaxis in particular, you have multiple body systems that are involved, and that's one of the things that defines it for us. So this IgE, what does the IgE actually do, and how does it produce this kind of reaction for people? So if you look at the picture on your left, you see a mast cell. And mast cells are cells that live in our skin, in our gastrointestinal tract, and other places, in the airways. And most of the time, they just sit there in those tissues. But they have on their surface IgE molecules. So once you've made IgE to these various foods or whatever it may be, it sticks onto the mast cell and it just sits there. And as long as no milk or no peanut comes along, Nothing happens, just sits there. But once the peanut kind of happens by and the right protein happens by, then that IgE sticks to the peanut, and the other IgE here also sticks to it, and it brings those two molecules together on the surface of the mast cell. And that causes the mast cell to dump all of these kind of chemical messengers that your body uses to create allergic inflammation into those tissues. And that's what you see happening on the right, is all of the these granules are going out into the tissues, and they cause the symptoms that I talked about with hives, swelling, wheezing, and the like. And then this is an example. This is an example of a picture of what a mast cell actually looks like. And you can see over on the left, it is just absolutely stuffed full of these kind of chemical mediators in those dark granules. And those granules then on the right have all kind of dumped into the periphery of the tissues, and they are all, and all of that stuff is out there causing inflammation now. And that's what happens in an allergic reaction. Now, we talked about anaphylaxis, which is when multiple systems are kind of involved, but that's not the only kind of IgE-driven process that you can have. So you see here there's also anaphylaxis, there's immediate GI hypersensitivity, which are, say, the kids or people who only vomit when they have a food they're allergic to. You'll have people who only get swelling. You'll have people that only get hives. Sometimes you'll get people who only have hives when they put the food on their skin, but they don't get hives at other times. It's contact urticaria. And then you can also have oral allergy syndrome, which is when you get the kind of itching in your mouth that many people get with kind of fruits and vegetables and seems to be related to pollen allergies. So those are all IgE-driven reactions. So those all would fall into a category of what we refer to as allergy. Notice that there are some things in the middle here that are labeled mixed. And that's because the IgE is involved in these things, but it's not really as clearly involved as it is with those other kinds of reactions that I talked about. So people that have atopic dermatitis or eczema, the IgE is important there. It's doing something, but it's not the only thing, and it's not probably even necessarily the most important thing going on there. Similar for eosinophilic esophagitis, which is a kind of allergic swelling in the esophagus that people may get. That is also kind of IgEs around, and it's involved in some fashion, but probably not very in a very direct or important way. And then, of course, there are, like I mentioned, the immunologically driven kinds of reactions that don't have anything to do with IgE at all, like celiac disease, or food protein-induced enterocolitis, which some of you may have heard of, FPIES, and a variety of others. So those are also caused by the immune system, but they don't have any particular relationship to IgE. So if we know that IgE is responsible for these at least for the allergic reactions, then it makes sense that if we tested for IgE and we could test what kinds of IgE would bind to particular foods, and if you make that kind of IgE, then you might be more likely to have an allergy to that. And that's, in fact, what happens. And you can test these things. But if you think about all the stuff that I talked about with regards to the mast cells and all of these other things that are unfolding when you have an allergic reaction, you see that it's not only that it's not just that there's IgE around. There's a whole bunch of other things that are happening at the same time to actually produce an allergic reaction. So if you only have IgE, it doesn't necessarily absolutely mean that an allergy is going to follow that, because so many other things have to happen as well. And this is what we see when we talk about testing. Testing is not nearly as reliable as people might imagine it to be. It doesn't mean it's not helpful. It is helpful. It does help us figure out which kinds of things might be likely to be causing reactions, and it gives us an idea of what the likelihood is that somebody will react. But it never tells us an answer. And if you look at the row there that's labeled the positive LR, which is the positive likelihood ratio, that's a good way of gauging how accurate, how useful a test is when it's positive. And in this case, you see for like milk, egg, wheat, and soy, both for skin prick testing on the top and for the serum testing on the bottom, that first of all, both the skin prick test and the serum test are pretty close in terms of their their overall accuracy. But the likelihood ratio gives you an idea of like how many times more likely is it that if you have a positive test, you'll actually react when you eat the food. And so you'll notice that these are not particularly high. When we think of a really good test, we're starting to tend to think of likelihood ratios more like 8, 9, something like that. These are about 2 on average here. So basically, if you have a positive test of any degree, you're about twice as likely as someone who doesn't have a positive test to actually react when you eat the food. So what does this actually look like in real life here? So say we we went out on the street and grabbed somebody who was walking by and decided to test them. Well, when we just grab them off the street, they have about a 1% chance of having an allergy. That's sort of the overall number for somebody taken at random from the population. If we then apply that likelihood ratio and say you're about twice as likely to have a reaction if you have a positive test, if this person that we just tested randomly off the street has a positive, say, peanut IgE, then you're having about a 2% chance that they'll actually react. So it's important to realize that these tests they're changing the probabilities that you have a reaction, but they're not really telling us for sure that you're actually going to react. Let's take a look at another case. Somebody walks into clinic and they say they have a food allergy. Well, it turns out in that case, if you compare that with sort of challenging somebody and giving someone a food, that they have about a 30% chance of having a food allergy if they walk in and just say they do. So if they walk in and say they have a food allergy, then it's about 30%. And then if you apply that likelihood ratio again, then it goes up to, a little less than 50% chance that they have a food allergy. So still, not a huge change as a result of your testing. Then finally, let's say we've got even a patient who has a convincing history of a reaction. They come in, they tell you they had hives and they had swelling when they ate a peanut. It turns out that there's still only about a 50% chance that they actually will have a reaction again when you challenge them. So even a patient with a convincing history, when you retest them, it really goes up to only odds of about 2 to 1 that they'll actually have a reaction. So the key to notice here is that the test, looking across these rows here, is actually changing things less than your history about what you know about the patient. The difference between someone who has a convincing history of a food allergy is much different than the person who was randomly grabbed off the street. So in fact, the thing that tells us most about whether you have a food allergy or not is actually us listening to your history. So that's why we spend so much time listening to what you're saying about what actually happened when you eat the food, because that's the biggest thing that changes, that moves the needle about whether you have a food allergy or not. The other things that we can look at in deciding whether somebody has a food allergy is by looking at the types of foods that you're reacting to. Turns out that the vast majority of food reactions, food allergies, happen in response to a relatively limited number of foods. These 8 foods listed up here, I think calling it tree nuts is a little bit cheating because they're actually quite different when the different tree nuts run from each other, but we'll call it 8 for the sake of being consistent with everybody else. So that includes milk, egg, crustaceans, fish, tree nuts, wheat, peanuts, and soy. So almost all of the food reactions can be explained by those 8 foods. This is because in order to have an actual allergic reaction, you have to not only have IgE, but that protein has to get to the right place to react, and all of those other things have to unfold with the mast cells and all that to make the allergy actually happen. And there's only certain proteins that actually have the appropriate characteristics to do that can survive the trip through the stomach and all that acid and all of that sort of thing. So only certain proteins can do that, and that's why there's a relatively limited number of foods that cause it. So the type of food that you're reacting to is another important thing in deciding whether somebody, in helping to decide whether somebody has a food allergy or not. There are some foods that may produce other kinds of allergies, like fruits and vegetables, like I already mentioned, actually are quite famous for causing oral allergy syndrome, but they almost never cause anaphylaxis or the more serious kinds of food reactions. So those are why we still think that, again, most of these food reactions are going to happen to one of these 8 different foods. Now, has there been an increase of food allergy over time? People talk a lot about this, and there certainly does seem to be evidence that the rate of food allergy, the number of people who are affected by food allergy, is increasing over time. The data is a little bit old in this slide here, but you can see that the rate of reaction is doubled or even tripled, and sometimes in terms of the number of people with peanut allergy in the UK and in the US. And in addition to that, the hospital admissions for food allergy, which is kind of a marker for how severe a food allergy is, those have increased also about threefold over the same time period. And that increase was almost all in the very young 1 to 5 age group. So if there is this increase in food allergy over time, where does it actually come from? The most well-developed explanation of why allergies are increasing comes from the hygiene hypothesis. The hygiene hypothesis is often sort of simply phrased as, because we live in a clean world now, we don't get infections anymore, so our immune system is bored, it doesn't have anything to do, and so it creates allergies instead. That's a little bit simplified from what's kind of really happening there. What it really appears to be going on with the hygiene hypothesis is that because we have less exposure to microbes in general, not necessarily pathogens, not necessarily things that cause disease, but we're exposed to more different kinds of microbes in general, or we're not as exposed to as many now as we were before, our immune system gets biased towards making allergic responses instead of biased toward making those other kinds of immune responses. And one of the studies that looked at this that I thought was particularly elegant was comparing the Amish and the Hutterites, which are two religious groups. They're very similar genetically. They come from a very similar background, Germanic kind of background. But they have very different practices. The Hutterites are a very communal group. Their farming is large, mechanized, typical U.S. Type of agriculture. The Amish are very focused on family, and less on a communal kind of operation. And so they operate very small farms, and they milk animals by hand. And so they have a much kind of closer personal relationship with the animals than you do in a more mechanized environment. And that's kind of what you see here in the difference between the two farms that are operating here. And you can show that there's a lot more exposure to microbes, and there's a lot more exposure to endotoxins that are produced by these microbes, and that's a good thing for your immune system in terms of preventing allergies. So when they did the study, you look at and compare these two groups, which are otherwise very similar except for their farming practices, and you find that, lo and behold, the Amish actually have basically no allergy whatsoever. And the Hutterites have an enormous amount of, not enormous, they have typical rates of allergy for the U.S. population. So there is something to, again, these older practices. Not to say the mechanization is evil or bad. It allows you to produce a lot more food and all of these sorts of things. So there are trade-offs in the world, and one of the trade-offs to having mechanized farming and increased farm productivity is that you have you have more chance of actually ending up with allergies. So what other kinds of risk factors are there out there for allergies? Well, one of the largest risk factors for food allergies is actually someone who has eczema. So if you have eczema or atopic dermatitis, you're about 6 times more likely to have food allergy than someone who doesn't have eczema. And we also know that if you treat the eczema, if you use topical steroids to get that eczema under control, if you grease the kids up with lubricants, that you actually reduce the rate of food allergy in those kids. So they don't acquire new food allergies if you're doing that. So why would that be? Well, it turns out that one of the key features of eczema is that the barrier function of your skin, one of your jobs of your skin is to be a wall, right? It separates you from what the rest of the world is. So if your wall has holes in it, then when you put food on your skin, then the food can sink fairly deeply into your skin if you have eczema, much more so than it would in a person who doesn't have eczema. That's one of the reasons that we do prick skin tests. We have to prick the skin because in people who have normal barrier, skin barrier, the food doesn't get, the drop that we put on your skin doesn't actually get in. You have to prick the skin to get it past that barrier. But if you put on a drop on the skin of a person who has eczema, boom, it explodes right away. You don't even need to prick them. So if you have eczema, you don't have that skin barrier, and the food can get deep into your skin, and it goes to the cells there that recognize that and start to produce allergic inflammation. So we know this also, too, from studying people who have changes in a gene that is responsible for that skin barrier. And that gene is called filaggrin. So if you have a change in this filaggrin gene that makes it more likely for you to have a porous skin barrier, you tend to have very dry skin, and you tend to have eczema. You're much more likely to have eczema. You can actually tell kind of whether you have filaggrin changes or not by looking at your hand. That's why I have a hand up there. This is a hand of a 3-year-old girl, happens to be my daughter. And you can see that she's got a whole lot of lines on the palm of her hand, especially right here under the thumb. That would be fine on my hand, but it's not fine on a 3-year-old girl's hand. So all of those little lines crisscrossing there are an indication of that filaggrin, that loss of filaggrin and the loss of and the dryness of the skin and the loss of barrier function in the skin. And it turns out that not only is filaggrin a risk factor for eczema, but it's actually even a bigger risk factor for food allergy. So how do we put it together then? So more recently, has been this hypothesis called the 2-exposure hypothesis. And this may help explain why the practice of avoiding foods early on in life did not help to prevent allergy. So if skin exposure leads to sensitization, well, it's possible then that maybe if you are eating the food in your mouth and you're just going through your GI tract, then that may teach your body that it's actually an okay thing. So if it sees it on your skin, but it also sees it that you're eating it, then it knows, oh, I don't need to worry about that. That's okay. That's just something this person's eating. But if it goes on your skin and it never sees it in the intestines, then maybe it thinks, for all it knows, that that peanut is a parasite of some sort, and it needs to create an allergic response to it. So in this way, it actually argues that allergies would actually be prevented by eating the food. So you think, well, okay, that's fine, but my baby who has peanut allergy, she reacted the first time she ever ate any peanut, so there's no possible way that this could happen. And we don't have any peanut in our house, so we're not putting it on her skin. So how could it possibly be she be sensitized? But it turns out that if you look around, there's peanut everywhere in the world. It's in cushions and the chairs. It's actually everywhere. And in fact, when you tuck your child into bed at night, you're basically tucking them into a peanut butter sandwich, even if you don't have any peanut in your home. And that was shown on the graph over here. This was part of the LEAP study, which you'll hear about a little later. And basically, they were looking at how much peanut was in the homes of children who participated in the study. And people who had, and you could certainly see the people who were eating peanut there on the right, they had a lot more peanut allergy, or a lot more peanut allergen in the home, a lot more peanut protein in the home. But the people who weren't eating peanut also had pretty high amounts and pretty definitely detectable and some quite high amounts of peanut, even though there was no peanut in the home at all. So you're going to hear more about that later, so I'm not going to dwell on it. But again, putting the food on the skin seems to be a bad thing, and putting the food in your mouth is a good thing. So what we want to do is keep kids putting the food in their mouth and not putting the food in their skin. So many of you may know about Michael Pollan. He's a food writer from the Bay Area, and he wrote this book called The Omnivore's Dilemma. He talked about how people face difficulty in making food choices because they have the ability to eat almost anything, i.e. they're omnivores. And the abundance and development of food technology means that there's all these different things you can eat, and so you tend to make bad choices. And as a part of this, he came up with these food rules that he thought were sort of a synthesis of what constituted a healthy diet. And that was that you should, 1, eat food. So it should be food and not things like, processed chemicals and things like that. So eat food as much as possible, not too much, and it should be mostly plants. Now, in honor of this, I have come up with the allergist's dilemma, which is that eating foods is important to being able to preserve your ability to eat those foods in the future. You have to be eating foods in order to keep eating them down the line. However, for some kids, eating them involves some degree of risk if you don't know how they're going to react to it. And for many, it's actually impossible because they are already allergic to the food, and so they can't eat it. So the best way that we have right now to get around that is a kind of prevention. And so I think my rules are that children should eat food, and they should eat food until they can't anymore, which means you don't stop foods before kids actually have a reaction to the foods. And this is true even for highly allergenic foods. So thank you for your attention. Next up is Rebecca Saenz, who is going to be talking to you more about this idea of preventing food allergies.